So good evening, everyone, and thank you to the organisers and to the group for inviting me to speak tonight. I hope you find the talk useful. As Callie mentioned, my name is Tanya. I'm a medical oncologist working at Westmead and Blacktown Public Hospitals. So in relation to bladder cancer, I generally treat patients with chemotherapies, immunotherapy, and at least in a clinical trial setting, newer agents that are currently under investigation. I will try to stick to my brief of discussing the immunotherapy agents used in bladder cancer. But I guess for some of the people that are joining in tonight for the first time or haven't heard a lot of the previous talks, I'll also briefly cover some other general bladder cancer information, and that may help put what I'm discussing in terms of immunotherapy in perspective and context. But hopefully it's not too repetitive for the few of you who've probably heard some of all this before. So flick that over. To briefly outline, I'll cover some of the bladder cancer background in relation to stages, mainly to highlight where different therapies, including immunotherapy, are being used. And then I'll concentrate on the immunotherapy treatments, including those triggered by directly putting them inside the bladder, such as BCG treatments, as well as what Callie referred to as the more trendy immunotherapy, the more recent years, what we refer to as checkpoint inhibitors. So to start with, some statistics that will not be a surprise to a lot of the people in this group, but why they're important is because they highlight why bladder cancer should continue to be investigated, should continue to be a priority in clinical trials, and essentially one of the reasons I really like working in that space. So as we all know, bladder cancer is unfortunately diagnosed in more than 3,000 people per year. It's got a male predominance in a 3-to-1 ratio, and bladder cancer actually makes up 2.2% of all new cancer diagnosis. It's the 11th most common cancer in both men and women. And unfortunately, about 1,000 people die each year from bladder cancer. Risk factors include smoking and other chemical exposures, but there are quite a few patients who have never smoked who also get cancer, and it's not clear why that happens. Not flicking over. Bladder cancer types, this is actually talking about the cell type, so what we see under the microscope after the cancer's cut out or a biopsy is taken. Most of them are something called urothelial, previously known as transitional cell carcinomas. They're the most common tumour cell type, and that's where a lot of what we know about the treatment in bladder cancer comes from. Very rarely, there are other less common cell types such as squamous cell, small cell, adeno, and these are important because they're essentially treated in a little bit of a different way, especially from the perspective of a medical oncologist. So stages, a lot of people like to know their bladder cancer stage, or that term gets thrown around as in terms of how, as in people want to know their stage and what that means for them. Rather than talk about stage 1, 2, 3, or 4, which is referring to something called the T&M staging, I like to look at stages in bladder cancer in how they would change how you treat them, and also how it would change whether you're aiming to cure them or not. So stages in bladder cancer are generally split into non-muscle invasive or superficial bladder cancer, muscle invasive bladder cancer, as well as advanced or metastatic. So as you all know, all these stages of cancer, there's usually a big team that's involved with different types of doctors that are all involved in treating the cancer. These include a urologist, which is a surgeon that specialises in genitourinary surgery, radiation oncologists, medical oncologists like myself, and sometimes palliative care or symptom control doctors, especially when there are symptoms that we can't control without their expertise. The types of bladder cancer treatments used include surgery, either just to take the tumour out or to take the whole bladder out. Intravesical agents, which essentially refers to agents that are put directly into the bladder, such as BCG and sometimes chemotherapy. Radiation, either to the bladder or to other sites if they're painful, as well as chemotherapy and immunotherapy or checkpoint inhibitors. Of those, the BCG, which is an intravesical agent, and the checkpoint inhibitors are considered immunotherapy, and they're the ones I concentrate mostly for the rest of the talk. So in a little bit more detail, when you split it to stage, non-muscle invasive bladder cancer or superficial bladder cancer, that's generally you do a TURBT. Fancy word just means that with a so going through the urethra into the bladder, you cut out the tumor. And in this space, if BCG doesn't work, sometimes surgery is also offered. And importantly, there are also clinical trials in this space investigating immunotherapy. Muscle invasive bladder cancer, I won't be concentrating very much on that in this talk. I suspect you've had previous talks on that, but essentially the way it's treated is with, again, surgery to remove the bladder or chemotherapy and radiation at the same time. Again, the reason to highlight it there is immunotherapy is entering this space, and there's a lot of clinical trials that add immunotherapy to what is considered standard treatment in this setting. And finally, advanced or metastatic disease, which is cancer that's beyond what we think we can cure. That's where we use chemotherapy agents, as well as it's the space where all the immunotherapy agents are showing a lot of positive outcomes. And in this setting, of course, we're looking at immunotherapy combinations with chemotherapy, as well as combinations of 2 different immunotherapies together. Okay, so just starting from the beginning, bladder cancer, the initial treatment that a patient will undergo is basically an attempt to get the diagnosis and the cancer out. A cystoscopy is done, you remove the tumor, and this also helps stratify the type of cancer into low, middle, or high risk disease, and that essentially decides how to treat it going forward. Intravesical treatments, or treatments that go directly into the bladder, refers to treatments that are inserted directly into the bladder. And why they are used is because it allows for high concentrations of any given treatment to be mainly in the bladder area and potentially kill any remaining tumor cells after the surgery. The examples of these treatments are BCG, and sometimes we even put chemotherapy directly into the bladder. Straight after the surgery, when you take out the tumor, you sometimes get given chemotherapy directly after the surgery, and this is just a single dose. It's given again via a catheter. It's left in the bladder for about 60 minutes. And the reason it's used is because it reduces the risk of the cancer coming back. This is mainly used alone in low-risk bladder cancer, low-risk superficial cancer, while in the more higher or intermediate risk, you generally use a combination of BCG later. The side effects of this treatment include inflammation of the bladder, and you can also get flu-like symptoms and rarely an allergic reaction to the treatment. So the intravesical treatment that is considered the most effective and has the greatest evidence is a treatment called BCG. It's used following surgery in high-risk disease, as I said a little bit earlier, and it's quite effective in reducing the risk of the cancer growing back. This treatment's usually arranged by either a urologist or a medical oncologist. So in some centres, such as ours at Westmead, a urologist would generally supervise this treatment, while in other centres, the medical oncologist does it because the urologists aren't as highly skilled in this area. But no matter who administers it or who arranges it, it's usually given by a very, very experienced nurse who's actually providing the treatment at the time. Again, usually it's administered weekly for 6 weeks, and then there's a maintenance schedule after that. So what is BCG? What exactly is it? It's actually a germ, a bacteria, essentially, and it's a weakened form of that bug or germ that's placed directly into the bladder via a catheter. And it's considered one of the oldest forms of immunotherapy. So immunotherapy is essentially anything that takes advantage of a patient's own immune system to try to fight the cancer. And it's been in use for decades, much longer than some of the new trendier immunotherapy. So, and it is still the gold standard in the treatment of early bladder cancer. So how it works, essentially the bug itself reaches cancer cells and turns on the immune system. The immune system cells, so all the different cells that make up the immune system, are attracted to the bladder and then attack the bladder cancer cells. And essentially the immune responses that it triggers just by being there can persist for several months, even after the actual agent itself or what the substance that's put in there has been removed. The side effects of BCG treatment include things like fevers, aches, chills, fatigue, essentially things that are switching on the immune system. So just the way that you would react to any infection, you tend to react to the BCG in the bladder. And more locally, you can also get side effects such as bladder inflammation, and this essentially means that the patient might experience some burning in the bladder. They may be passing urine much more frequently, and they can also notice blood in the urine. Very, very rarely, the BCG, especially if someone's immunosuppressed, the BCG infection can actually spread in the whole body. Now, when should we avoid BCG treatment? Essentially, if somebody has a lot of blood in the urine, we should wait. If they've got an active urine infection, we should wait. And if they're unwell in other ways, then we should wait as well.
Well, can I ask you a question about the COVID vaccination? This has come up a lot. Do you have to wait for a certain period after getting it?
No, so generally, I think with all treatments, so this is chemotherapy that's going through the veins, immunotherapy going through the veins, or local treatments, we generally say we want our patients to receive the vaccine as soon as possible. In terms of what the guidelines say in relation to the timing of treatment, there aren't any clear-cut guidelines. What I tend to say is just so you're not getting the side effects at the same time, more than anything about the interaction, and just so they don't interfere with your next dose of treatment, I generally say to do it a few days after. So most with the COVID injections, there's sometimes a risk of a fever or sore arm or feeling a bit off for a day or so. So if your treatment, whatever it is due the next day or the 2 days later, it might interfere with you getting there. So I generally say a week or so later. But BCG with those 6 weeks, look, waiting a couple of weeks if you've got a 6-week schedule is reasonable, but I don't think I would avoid having the injection during the treatment. Is that what you tend to be saying in the urology world as well?
Yeah, that sounds about right.
Yeah. And in general, all my patients on other types of treatments don't tend to, it doesn't seem to interfere in any way. Half of them don't even ask me and come and tell me they've had the vaccine afterwards, which is fine. And okay. So BCG, as I mentioned, is the gold standard in terms of in reducing the risk of recurrence in early bladder cancer. However, if patients are intolerant to BCG, they have too many side effects, if they can't have BCG for any other reasons, they're immunosuppressed, there could be other reasons, or sometimes even when it doesn't work. And also, Kylie could speak to this as well, there was a time where there was a BCG shortage, or there still is a relative BCG shortage worldwide. And when that was the case, more immediately we tended to use some of these intravesical treatments a bit more in the form of chemotherapy. So very, very similarly, chemotherapy is put directly into the bladder. And unlike BCG, it wouldn't be considered an immunotherapy. So it doesn't work by activating the immune system. It's actually working by directly trying to kill the cancer cells. Mitomycin, gemcitabine are just two types of chemotherapy used. But essentially, look, these graphs that you oncologists love, it's just there to fill up space. But essentially, BCG is shown to work better in studies. Chemotherapy is another option, but there are a lot of studies looking at ways to make chemotherapy more effective, either by, for example, combining mitomycin BCG, and this is being done in the clinical trials setting, or warming up the chemotherapy. Similarly, the treatment's given weekly for 6 weeks. This is in relation to chemotherapy. It's actually more tolerable. You get less side effects than BCG, which is the reason why some people prefer the chemotherapy. But the side effects are quite similar. Otherwise, they just occur less commonly. So what I won't be covering today is intravenous chemotherapy, which is chemotherapy directly put into the veins and works on the whole body. I think that's been covered in previous sessions or will be covered in future sessions. But just again, to put it in context, just so you know what other treatments are used in the different stages, intravenous chemotherapy is standard in muscle invasive bladder cancer as an option as a neoadjuvant or adjuvant, or at the same time as radiation. And it's also standard in advanced or metastatic setting. Important to highlight, even in those settings, immunotherapy in clinical trials is being investigated, and we have several immunotherapy clinical trials across Australia that use immunotherapy in these settings. And I think I'll touch on that a little bit later as well. So changing tact a bit. So we're talking about the whole body, systemic immunotherapy, so to speak. And this is what the new trendier version of immunotherapy that people tend to refer to when it's in the news, when they're talking about melanoma and when they're talking about cures. So why it's so trendy, why for us it's such an amazing, I guess, treatment in a medical oncology setting is even in metastatic disease, we're seeing cures in the cancers that we've been using it for a while. And obviously the whole goal of everything we're doing is try to find out why it works so well in certain patients and be able to broadly treat all patients with treatments like that. So to take a step back, the immune system already, just a normal immune system, is involved in cancer, and that's what system you're manipulating to try to make these treatments work. So immune checkpoints are part of a normal person's body, and they're the target of the immunotherapy agents we use. So their immune checkpoints, their normal role is to prevent the immune system from being so strong that it attacks normal cells. So obviously, if this was switched on completely all the time, your body will fight its own cells and can make your body quite sick. So it's got a role in normal physiology. The way immune checkpoints work is they turn off the immune system by engaging. So these are just some cells. So this is an immune cell, a normal immune cell. This is a normal cancer cell. I wouldn't call it normal, but pretend it's a bladder cancer cell. And there's a few things or receptors or proteins on the surface. The immune checkpoints, by binding to one another, essentially tell the cell, T cell, not to attack it. And that stops it from destroying the cancer. So how does immunotherapy work? It's using the patient's own immune system to fight the cancer. So again, that same diagram, checkpoint inhibitors such as Keytruda, all these other immunotherapies that are starting to get used in bladder cancer, they block these. So back to that same diagram, can you see my cursor, by the way? Okay. They attach to where it's supposed to bind and stop the immune cell from binding to the cancer cell and telling it to turn off. And by preventing the off signal, it essentially allows your immune system to kill the cancer cell. And here I'm just circling what I'm talking about. And some of the examples of these types of treatments are, again, fancy words, PD-1 or PDL inhibitors, which are essentially one of these proteins. So that's a PDL1, that's a PDL, not PDL1, PDL1. And this is on the tumor cell, that's on the actual immune cell. And some of these agents block these from binding. CTLA inhibitors, again, another type of immunotherapy, and it blocks a different part of that receptor. So for those who that all went over their head like it did the first 10 times it was ever described to me, this is a bit of a video that tries to visualize what the T cell is doing. So how T cells fight cancer. Forward. Can you hear that and see?
Yes.
Okay. When a T cell encounters a cancer cell, an explosion of membrane protrusions explore the surface of the target. Cytotoxic T cells kill their targets with toxic chemicals. The chemicals are housed in these red structures called lytic granules. You can see the lytic granules polarized from the rear of the T cell to the blue cancer cell.
Okay, short but sweet, but that was borrowed from a melanoma doctor colleague. Okay, so checkpoint inhibitors, immunotherapy, all these agents that we're talking about, they are standard treatment for cancers such as melanoma. And when I talk about that blue sky of what our goal is in melanoma, they're showing cure rates in a percentage of patient, even when they have metastatic disease. In renal cell as well, a smaller proportion, and in bladder cancer, the data is not mature enough, but clearly they have an effect. So in bladder cancer specifically, they're PBS listed. So pembrolizumab, Keytruda is PBS listed, so reimbursed by the government in the second line setting. That's after patients have already received chemotherapy. And it's reimbursed in that setting because we know when it's used there, it makes people live longer than if they got chemotherapy instead in that setting. Now, even more recently, there's also been a positive PBAC recommendation. PBAC is essentially the governing body in Australia that decides whether things go on the PBS or not. They've also positively recommended for the use of maintenance of avelumab, so another type of immunotherapy, very similar in how it works to Keytruda, that if we use it even earlier, still after chemotherapy, but not wait for the cancer to grow, it may have even better effect. It's not yet on the PBS, but there's actually a compassionate access program, and it's free of charge to patients that meet the criteria for that. And I do have a lot of patients who are currently on this. So it's exciting that it's available free of charge to patients in the right setting. So there, what I first mentioned are the lines where immunotherapy is already in routine use in bladder cancer. But importantly, in bladder cancer, immunotherapy is actually being used in clinical trials in almost every single stage and setting, including at Westmead, in Blacktown, other places in Australia, across New South Wales. So a lot of the clinical trials that I have up here are actually available in Australia. So in a superficial bladder cancer setting, we're looking at adding one of these immunotherapy agents to BCG. In patients who don't respond to BCG but want to keep the blood, are not yet ready to commit to what is the gold standard of removing your bladder, there's also immunotherapy being tested in that setting on clinical trial. And again, some of the early evidence is positive. As I said, in that muscle invasive bladder cancer space, we're also looking at people who can't have chemotherapy or don't want chemotherapy, whether immunotherapy works in that setting. And of course, in the metastatic setting, we're looking at combining it with chemotherapy quite early or using combination immunotherapy in a later setting. So logistically, what is immunotherapy? How is it given? We kind of now know how it works. It's unlike the BCG, it's usually prescribed and managed by a medical oncologist. It's given as an intravenous infusion, so through a drip, very similar to how chemotherapy is given. You're an outpatient facility in a recliner chair. It goes through the veins really mostly under 1 hour, and then you can leave the department. We give it at the same place that we give treatment with chemotherapy and infusions and other type of treatments. In bladder cancer, when we're using Keytruda or pembrolizumab, it's given once every 3 weeks for up to 2 years, as long as it's working. And avelumab, which is the agent that's got the PBAC recommendation for use in the maintenance setting, is given fortnightly. So just like any treatment, the BCG treatments, chemotherapy treatments, radiation, surgery, immunotherapy does have side effects. And as I mentioned earlier, immunotherapy works by switching on the immune system against the cancer, and hence the side effects are generally related to the immunotherapy potentially switching on your immune system against some of your own organs. In general, most side effects are mild and are generally quite predictable and easy to manage, and we know how to monitor for them, especially with the use of things like Keytruda, where it's a single agent, not a combination or a different type of immunotherapy that has a higher risk of side effects. But occasionally there can be quite serious side effects that but the ones that lead to us actually ceasing the medication are quite rare.
Tanya, question.
Yep.
Does immunotherapy reduce or dampen the immune system in the same way chemotherapy does? I think I know the answer to this. Like,
No.
is it because chemotherapy affects the bone marrow and immunotherapy doesn't, or am I
Yeah, so just in general, immunotherapy works. It's a cytotoxic agent. It basically targets things that are rapidly dividing, such as cancer. So that's why it's such a good anti-cancer treatment. You're targeting the cancer cells, which could be rapidly dividing. The other cells in the body that could rapidly divide or do rapidly divide are things like hair follicles, blood cells, such as red blood cells, white cells, especially because they divide quite regularly, and platelets. So by targeting the blood cells, this is chemotherapy, you do get immunosuppressed and there's less immune system cells, and that's why it affects your immune system. With immunotherapy, it's quite the opposite. We're actually activating your immune system. So although there are some rare cases where one of the side effects is that it reduces the cells of the bone marrow, that's quite rare in a very different way that chemotherapy does that. So I wouldn't generally say that a person on immunotherapy is at higher risk of getting an infection or at higher risk of getting other side effects that you usually associate with chemotherapy.
So they don't have to be, yeah, no, it does. So they don't have to be isolated in wards with low white cell counts.
No, not at all. So generally one of the biggest things we educate patients about when they're having chemotherapy is if you get a fever, you have to come straight to hospital, at least contact us if it's within work hours. They generally need to be isolated. We check their blood cells and give antibiotics. And most of the time they're actually quite well, but we wait for their counts to recover. With immunotherapy, if you get a fever, we don't behave that way. We let it go. We tell you to take Panadol. It's very unlikely that your immune system is low. So we wouldn't treat you in the same way as we would someone with on chemotherapy who's at risk of their immune system being affected.
Does one more question related to side effects? Does it affect the thyroid gland?
Yes, I think I've got that on the next slide. So essentially, this is just from Cancer Council New South Wales, and all it really wanted to point out is that any organ in the body can technically be affected if your body chooses to basically activate against it. But most commonly, especially with drugs like pembrolizumab, Keytruda, which we use in bladder cancer, most common things that people notice is that they're a bit tired or some fatigue. Common side effect is that you notice a bit of a mild rash or an itch. And the most common effect on any organ on the body is actually on the thyroid, as you pointed out. So again, most patients don't notice it. We pick it up on the routine blood test that we do before each treatment and treat it before it becomes a problem for the patient. So it's a very predictable side effect. Probably happens in about 15% of patients, and the way we treat it is by giving hormone replacement, which is essentially thyroid replacement, and we check for that on every blood test. The rest of the side effects, especially with the use of pembrolizumab, are much less common and include, and the things that we say to patients is, if you have diarrhea, if your breathing changes, we want to know straight away. They're the two things I generally tell a patient. The rest of the side effects, we generally pick up on our routine blood test before the patient notices it. But if the patient notices diarrhea or shortness of breath, we want to know as soon as possible. So that would be the two things that are just as important as having a fever while on chemotherapy.
Another question related to thyroid: is Graves' disease a contraindication to getting Keytruda?
On a clinical trial, yes. In reality, if the Graves' disease is well controlled, if it's burnt out, if we've had a discussion with the endocrinologist or whoever's treating it, I have safely treated patients that have a history or are on treatment with Graves with immunotherapy after having a risks benefit conversation with the patient. So yes, mostly if the autoimmune, even patients with a previous history of autoimmune diseases, we've learned that we could safely treat them as long as we're aware of it, we know what to look for, and we have a discussion with their previous specialists. In a clinical trial setting, unfortunately, because they're obviously very strict, we don't know if the treatment is useful or not. They're a little bit more stricter and exclude patients with a history of autoimmune disease. So Graves is probably excluded, but if you have hypothyroid and you're on thyroxine, for example, a clinical trial will usually let you on. Does that answer that?
Yes, it does. Thank you.
Yeah. So, and that's just with everything. Obviously, when immunotherapy first came out, we know we were activating the immune system. If a patient has a history of an autoimmune condition, we're worried that activating it will make that condition worse. So if someone has colitis, ulcerative colitis, Crohn's, theoretically, we can make that worse. And not only theoretically, that we're trying to activate the immune system. So all the clinical trials excluded those patients. After, for example, in melanoma, we've shown that it has an excellent overall survival benefit. It can sometimes lead to complete removal of the cancer, at least on scans, for a long time. Then people who had those conditions wanted to take the risk and try the treatment, and then more and more evidence from those particular case studies came out that it can be done safely.
Makes sense. Thank you.
Okay, so as I said, the diarrhea, the colitis, inflammation of the lungs, they're my usual things that I want to highlight with the patient, because they're the things we want to know about quickly. We don't want you to just wait for your next appointment to tell me you had diarrhea for 3 days in a row. Okay, just take it back a bit again. The side effects, as I said, they're usually quite predictable, and we've got a very, very good algorithms to how to treat them. We have very good immunotherapy trained nurses who essentially, I think there's a typo there, but we know how to treat them and what works. And generally, if things don't work, we have an automatic next step. But as I said, most commonly it's a skin side effects, a bit of a rash or an itch without actually seeing a rash. It tends to be for a few days after the treatment and then it goes away. But we sometimes have to use topical creams, sometimes with steroids in them. Hormone replacement is how we treat most hormone problems that come as a result of having immunotherapy. And when things are more serious or affecting the liver or the diarrhea issue that I discussed, then we may need to use oral steroids and sometimes even steroids through the drip. Very, very rarely we use stronger immunosuppressive agents if the immunotherapy turns on the immune system so much that it's causing a lot of damage to any particular organ. Sometimes we can manage with all those simple things and still continue the treatment. Sometimes we stop it for a cycle or two, and if all the side effects go away, we start again. And sometimes we say, let's just stop the treatment. The side effect seems to be a bit too annoying or disruptive or damaging. So essentially, in summary, immunotherapy in bladder cancer is used in early and advanced disease, but there's ongoing studies in all stages of treatment and in combination with all treatments that are already used. A lot of typos on that one. Immunotherapy has improved outcomes in bladder cancer. Not only is it decreasing the chance it will come back in the early disease, but it also is making people live longer in the advanced disease setting. And as I said, clinical trials with an immunotherapy component are available in almost all stages of disease. And slightly unrelated to immunotherapy, but just like immunotherapy 10 years ago wasn't used in bladder cancer at all, we've also got a few different agents on the horizon in bladder cancer that a few years from now would have evidence that's just as in enough follow-up as we do with immunotherapy at this stage, and that includes things like FGFR targeted treatments, which is a mutation that's commonly found in bladder cancer, as well as other targeted therapies that are looking at parts of the bladder cancer that are quite common in all bladder cancers.